My name is Nick Guenzel, and I'll be giving this presentation on research with Native communities. Upon completing this module, you should have a better understanding of factors surrounding the promotion of ethical research with Native Americans. You should be able to give recommendations for promoting research with Native Americans. You should be able to list the issues facing Native American communities interested in research. You should be able to discuss the values considered core for tribes in conducting research. And you should be able to list the steps that must be taken to successfully conduct research with Native American communities. Despite some of the historical and even more recent challenges with regards to research among Native American communities, research does hold significant promise for Native Americans. Unfortunately, Native communities tend to be underrepresented in major data collection efforts. Native American communities also face some of the greatest health disparities. And lastly, research can help communities identify some of these problems and find solutions. Before we get into more of the details of research with Native American communities, we really have to review some of the troubling events that have happened in history which have eroded trust from Native Americans for the outside researchers. And so the ones we're going to discuss today include disfigurement and the collection of body parts, trachoma, the thyroid gland study, sterilization, and the Havasupai diabetes study. As most of you are probably aware, in the 17th and 18th centuries, military doctors collected body parts from Native Americans, from battlefields, and from hospitals for their studies and for their research. Now, they probably did not understand or maybe care about the fact that this conflicted with many of the beliefs of the tribes that the body must be intact for the spirit to be released. Trachoma is a serious and contagious eye condition that can lead to blindness among many people. Between the years of 1897 and 1924, doctors on reservations across the South performed radical surgeries, including often the removal of the supporting structures of eyelids, in an attempt to eliminate trachoma. So overall, it seems like their goal was good. However, their methods that they went about to achieve this goal was not appropriate. And the question that comes to my mind is that they performed these radical surgeries on Native Americans on reservations, and would they have performed the same surgeries, for example, if their family members had suffered from the same afflictions? And so many of these people suffered from lifelong consequences, for example, never being able to close their eyes again, if you can imagine the difficulties that would entail. The next abuse we'll review was the thyroid gland study. So this study was completed by Air Force researchers in the 1950s in Alaskan villages. And during this study, the researchers administered a radioactive form of iodine that damages the thyroid gland to various Alaskan natives. So the safety guidelines were not followed for this study, and it's quite doubtful that any such study would be approved today. Another major problem with this study is that adequate records were not kept, making it impossible for the researchers to follow up with individuals, to assess their health status, and to provide any needed treatment. So really, it's unclear how many people were harmed as a result of this, how many women might have been pregnant and whose offspring might have suffered consequences. And so clearly, this is something we need to learn from and definitely not repeat anytime in the future. Next, we have sterilization, which was committed in the 1960s and 1970s by the Indian Health Services professionals and their collaborating physicians. So for many of you, I realize the 1960s and 1970s may have seemed like a long time ago in history, but I think if you ask around your communities, and particularly among the elders within your Native American communities, you'll see that many of the people remember these events and have been obviously quite traumatic for many people over the years. So within the context of the sterilization, this was often undertaken with inadequate explanation, with little or no consent, and with coercion. In some cases, individuals were threatened with the loss of benefits from the Indian Health Services or other government benefits they were otherwise entitled to. And one of the more troubling aspects of this, even further, was that they performed surgery on some minors as young as 13 years of age, even though this was expressly prohibited by their regulations. The final example we're going to review today is the Havasupai diabetes study. And so within this study, DNA samples were collected between 1990 and 1994 for the purpose of a diabetes study. Now, in my mind, this is one of the more troubling examples with regards to research because it is so recent. It's not like this was conducted many years ago when we didn't have IRB protections. They did have IRB procedures, but unfortunately those procedures were not followed. So after the initial diabetes studies, these DNA samples were then used nationally and even internationally for research ranging from schizophrenia to inbreeding. So I think we can see that in part this may be, in the researchers' minds, an example of the ends justify the means. Schizophrenia, if you've ever known someone suffering from that condition, is very debilitating, and it would be a wonderful thing if we could start towards the research that would lead to a cure or prevention of schizophrenia. However, using samples from a study without consent is clearly not appropriate there. Also, with the inbreeding, is obviously another concern here. With this study, it's not like the eye surgeries for trachoma. It's not like the forced sterilization and that they had a great harm on those individuals. However, when these issues of inbreeding came out, there was tremendous stigma placed upon that community and upon the tribes, which left years of damage in that wake. So they had to, unfortunately, the tribe had to undergo years of legal battles to get the use of these samples to stop, and to get many of the samples returned. I believe up until this day, it's really unclear as to whether all the samples have been returned. And this again goes back to some of the core values of the tribe, and that those body parts or those body fluids must be returned to the tribe or to the individuals. Another aspect that is even kind of more impactful with regard, in my mind, for this is that more and more of the research we're conducting now involves the use of biological specimens, including DNA samples or other body fluids. So when we have this example of such recent abuse of research, this may create doubt in a person's mind. I mean, when you go in and these people were told we're collecting your blood for a study of diabetes, the tribe had a very high rate of diabetes, so it would seem like a very positive project for the community to participate in. However, those researchers went forward and abused those samples and abused the individuals they recruited and who trusted them to conduct this research ethically. Whenever we're discussing ethical violations with research, I think it's always worth going back and at least making brief comments about the Nazi experiments. You know, there's so many things about the Holocaust that were so horrific that today we like to think that these things were a historical anomaly and could never be repeated today. However, I think if we look in a little bit more detail, we see that we do have to remain careful and vigilant to prevent these things. Many of the Nazi experiments appear to be atrocious as they were, and really without scientific grounds or justification. However, if we look at some of the experiments in particular, for example, with the pilots that were downed in the ocean and freezing temperatures, or who were subject to high elevations, these researchers were tasked with conducting experiments that would help to ensure the survival of their pilots. So given the context of such severe propaganda, the dehumanization of the Jewish people and others who were interned in the camps, conducting these experiments in a wartime in the context of such propaganda seemed like a logical thing to do, I'm sure, for many of these researchers. So we just need to be careful that we don't get to the point, as many of the researchers have throughout history, that the ends justify the means. Now, hopefully the abuses that we reviewed are something that would never happen again. However, more recent research concern with regards to Native Americans specifically has been what they call helicopter research. So you guys might have heard of this concept, but it's basically a situation where a researcher or a PhD student or whoever it might be goes into a community, conducts their research, collects their data, and then leaves without ever having any further contact or a lasting impact or even the intention of having an ongoing relationship with the community. So as a result of this, some communities, an example here, the Cherokee Nation, have expressly forbidden helicopter research. They say that any research that goes on within their community must be of benefit to the individuals there and must be within the context of an ongoing relationship. And we see also that with funding agencies, this has become a concern. Funding agencies don't want to see researchers go in, collect their data, get their promotion, graduate, whatever their case might be, and then leave the community. So really, the research needs to be conducted within the context of a long-term relationship where the community are the people in the community are the primary ones who benefit from that ongoing relationship. So we'll next look at some of the disparities, the health disparities among Native American populations. And this, in my mind, is kind of analogous to what we see in journalism, where we've all heard, if it bleeds, it leads. People want to hear stories about dramatic things, about major problems, things like that. And the same is true to some extent with funding agencies. The funding agencies want to fund proposals that will have a significant impact on the community. So for example, if we have a community where we say everyone's fairly healthy, we would just like to see them get walking a little bit more, we pretty much have zero chance of getting a proposal like that funded. By contrast, if we go in and we highlight a community where we say the cause of death from, or the rate of death from this specific cause is 5 times greater than the community surrounding it, then we really have a more significant chance of getting that funded. So unfortunately, this kind of has to be looked at from a negative perspective, in that we're highlighting many of the problems within the communities. But I would say on the reverse side of that, we're highlighting many of the opportunities that we have to improve the health and to work with people in the community to improve their health and their longevity. So when we look at some of the leading causes of death, or we might say research opportunities in Native American communities, these include cardiac problems, cancer, unintentional injuries, and diabetes. Now, I put together this chart in another way to look at health problems among Native Americans, and I think in some ways this is more useful than the previous slide, which pretty much reviewed the overall causes of death. When we look at that specifically, cardiac is almost going to always be number one among the causes of death among different populations, largely because if people get old enough, they eventually have to have some kinds of health problems, and they're likely to have cardiac issues to some extent there. But with this chart, we're more looking at the rate among Native Americans compared to the national rate, and this is really where we can highlight some of the disparities. So for example, on the first line, we can see that alcohol-induced deaths is 6.6 times more likely among Native Americans than the national population. And the same with chronic liver disease and cirrhosis, followed by diabetes and the rest that we can see here. So this is really what we can use for example, a proposal to say we want to address the problems of alcohol-induced deaths among community X, and we can compare the rate in that community to surrounding communities or to national rates and say that this disease bears a disproportionate burden, or places a disproportionate burden on this particular community. So I'm not sure if you guys have had exposure to or discussion of the Institutional Review Board in any of the modules from the other colleges, but I think it is important to highlight briefly here, since it does play an important role in research with Native American communities in particular, and pretty much all research more broadly. So the purpose of the Institutional Review Board is to ensure the safety of the research participants. So every university or large hospital or other agency is going to have an Institutional Review Board, and really their role is to help to safeguard the health and safety of the participants there. This group reviews proposed research plans and really evaluates in fine detail what is going to be done to make sure that there is minimal and justifiable risk for the participants. This group also represents a wide variety of professionals, so oftentimes on the board we'll have representatives from medicine, from nursing, from pharmacy, physical therapy, and other groups. And this is really to bring a diverse range of perspectives and specialties to the review of individual research proposals. The IRB application includes plans for ongoing data monitoring. So the data is within a particular study, especially the longitudinal studies, are reviewed periodically to see if there are any major differences emerging. So for example, we've seen some of the more recent research with regards to proposed COVID treatments, and then we see if they don't show improvements, or if the proposed treatment is actually looking to be worse than the standard of care, then that study can be halted early. And the same is true with any other study. If they see very different outcomes at an early stage between the treatment group and the control group, or between two different treatment groups, then that study can be halted early. And there are also special protections for vulnerable groups. And this comes up with a variety of groups, including, for example, individuals who are incarcerated. So there are special protections for that group in saying that research cannot involve incarcerated individuals if it is only to benefit the larger population. So vulnerable groups, including people who are incarcerated or minority groups, cannot be used as guinea pigs to gain information that would benefit only the larger society. And I would think that we'd see the same thing largely with regards to Native Americans. Really, any research that we do in collaboration with Native American groups is almost always going to be of pretty much exclusively benefit to those Native American groups. Another important entity that we need to discuss when regarding research with Native American groups is the Tribal Council. So this Tribal Council is set up as an element of protection for research involving tribes. This can be a challenge for some researchers because it's often quite different from, for example, the IRB applications and process that we have to submit for. The IRB is very extensive. They look through pretty much every word that we write in our proposals, but to some degree it's largely predictable. We have a calendar laid out that we know in 9 months from now they're going to meet on a certain date. We have certain deadlines, and so everything is pretty well laid out at that point. However, with the tribal councils, things I think can be a little bit less predictable regarding timeline, regarding different forms of membership on the tribal council. And so the timeline might be a little bit different for the tribal council than for other university-based groups. And so this needs to be taken into account, especially if we have research projects which are on a strict deadline and it happens that the tribal council meeting was canceled or postponed for whatever reason, then there needs to be some flexibility taken into account there. Again, this often takes longer to get approval from a tribal council than from an IRB, but it is essential to get buy-in from the tribal council and really to get their support. I don't see that any research is really going to be successful within a tribal setting if it does not have the support of the tribal council. Another challenge is that when we might have research that involves multiple tribes, unfortunately these days we see smaller communities which really may require that we involve multiple tribes in order to get to a larger sample size. However, each of these tribal councils may have different ideas on their priorities or which direction they'd like to see the project going, which can create challenges for the researcher. Also, there's a factor that the change of leadership may affect the outcomes or the decisions that the tribal council makes. So within the IRB, we can have changes of leadership or changes in membership, but in large part, that's a set body. They have set priorities and duties there, so it really doesn't matter who is in charge of a particular application. The process is pretty much the same. Whereas I could see this could be quite a bit different with regards to a tribal council, where if we have a drastic change in leadership and the new leader has very different ideas, or the new council has very different ideas than the previous council, that their priorities may change and that their relationship with the researchers may change as well. So in this slide, I've kind of drawn up a picture of what some of the relationships might look like. For example, if we have a research project involving 2 tribes, an institutional review board, and a funder. So for example, again, if we have these 2 different tribes that would like to take the research in 2 different directions, then that can be a significant challenge. If we have the IRB that wants, the IRB doesn't exactly lay out what they want the research team to do, but they will lay out, for example, how we must go about that most ethically and in the most safe way possible. Then we also might have the funder, which can have their own priorities there. So this can be a major challenge for the research team to really draw together all of these groups to come to a common platform. And it may be a situation where Tribe A and Tribe B might not always get everything that they wanted in the research project, but we need to work on compromises so that the goals can be achieved together. I'll next go through a few of the studies that I've conducted with Native American groups as some examples of research in this area. So the first study I conducted after starting at the University of Nebraska Medical Center was a study on historical trauma and mental health among urban Native Americans. So this was a mixed method study, and with this we conducted surveys of 140 individuals, and then we also conducted 3 focus groups to provide more context and interpretation. This focused on an urban sample, and I did this largely just because of the fact that almost all the research that's been conducted on historical trauma has been on reservation or with reservation populations. And so I thought the urban populations could vary quite significantly. In an urban setting, most of the time people are removed from their ancestral homeland, they're removed from their tribal structure and support. And another factor is that in an urban setting, they're most likely to come in contact with and develop relationships with people from a wide variety of backgrounds or different tribes or nations. Whereas if they're on a reservation, they're most likely to interact predominantly with people from a similar background. So this was really the first study of this scale to be conducted among a general population of urban Native Americans in the U.S. So we looked at historical lost thoughts, if you're familiar with that scale. So basically it goes through and says, how often do you think about the loss of your traditional language, your traditional spiritual ways, the loss of your land, and various other factors. This is also coupled with a historical loss associated symptom scale. So this scale asks, when you think about the loss that you experienced, do you feel anxious? Do you feel tired? Do you have problems sleeping? These types of things. So we can look at more of the psychological impact of those historical lost thoughts. We also looked at general mental health symptoms ranging from depression, anxiety, substance use, and others there. We then matched subjects with an individual from a national data sample so that we could look at various rates of different mental health symptoms and compare them between the two groups. So I did have a number of challenges with regards to when I implemented this project, and I think this would have been some of these would have been expected no matter what project I implemented, because this was the really first research project of my career. However, in working with some of the Native groups in particular, this led to some of the unique challenges that I'll review here. So the first was some of the interpersonal conflicts. So I thought from the beginning it was very important to involve the community, to take into account their perspectives and their priorities. And in fact, my focus on the historical trauma aspects of the urban Native Americans really came from the Southeast Native American Coalition, where I'd been attending some of these meetings, and I found that this was a major priority for them. So I sought out funding opportunities and did get a small grant to cover the costs of this study here. However, in involving many of the local people, I found that, for example, we conducted a training exercise with regards to these research methods and conducting focus groups in particular. But partway through the training, I realized that there was significant conflicts between two of the individuals there, and that neither one wanted to interact with the other. So you can imagine that this could create a significant challenge in that the training, we're supposed to involve significant degree of interaction and role playing, but we have two people involved in the training who won't interact with each other. So I think this is, obviously a possibility within any context, but I think is maybe more likely in smaller communities who are often more stressed for resources than it would be, for example, with a hospital board or a group of university researchers. We also saw some changes in leadership. So I had aligned with and went in and talked with the director of the Native American Center here in Lincoln, and he was very supportive of this project. However, then we had a change in leadership partway through the project, which created some challenges because we had to go back and recreate these relationships. And thankfully, things did work out, but I could see the possibility of more drastic changes or even issues in collecting the data in changes in leadership within that context. So for example, if we have changes in leadership in a hospital or a university system, they're more, I think in most cases, likely to continue on the projects and continue with very similar priorities as their predecessor. However, if we have a smaller community group and there's some significant problems within the group, we may find that a new leader wants to change some significant make some significant changes in their priorities or their direction there, which may call into question some of the research that's been engaged with there. We also had a different review process for this study. We obviously had the IRB application, but we also engaged with the community and made sure that they were okay with all of the methods and that they were supportive and thought that these could really work within the context of their community. Another aspect that was unique, I think, to this study and similar studies was the review process after the research was conducted. So after we collected all the data and analyzed some of the results, I arranged to have a community dinner where people could come in. I presented the results to the people and took in their feedback. And so this was very valuable, I think, on both sides. The community obviously wanted to hear the results of the study that they participated in. At the same time, I really needed and valued their feedback on the project. So for example, one thing that we found within this sample was that Native Americans that we conducted the surveys with reported much higher rates of what in Western experiences we might call hallucinations. So when I took this to the community dinner and discussed with them, they said that no, these are not like the hallucinations like might be experienced by people of European descent, but people from Native American backgrounds are more in tune with other spiritual aspects and wouldn't be exactly called hallucinations, and we wouldn't automatically jump to the conclusion that the person, for example, might have schizophrenia. So these insights were very important to me and provided a lot of context to help interpret the information before we ever looked at publishing anything like this, to make sure that we had an accurate interpretation of the findings that we got. Another aspect that of the review process that was different from most other studies was that I asked some members of the community to review the paper before we ever went for publication. So I kind of made the statement that this would be available to anybody within the community to review before publication, and I think this is quite different from most other studies, to where the researcher wouldn't necessarily go to anybody who'd been involved in the study or even anybody who hadn't been involved in the study but was a member of the community to elicit feedback. But this is something that I thought was important, again, to make sure I was interpreting the results accurately and was going to portray the findings appropriately. Another thing that I did that was different, I think, from most other studies is that I made kind of the data that we collected open to members of the community. Now, obviously, this was de-identified. We took out any information that might be that could possibly be used to identify individuals, but I thought that since the members of the community were engaged in this process, they participated, they helped me with data collection and recruitment, that they should be entitled to look at the data, and they could analyze it on their own, or they could come to me and we could analyze it together. So I really thought that was an important part of this process, which is not common within other aspects of research. And another unique aspect to this was the reservation status of a particular group, and in particular the Ponca. Their recognized tribal status was taken away some years back, and then they were reinstated, but they still don't have their own reservation. So they have 3 areas within Nebraska where they're interpreted to be on the reservation. So they can be, for example, within a particular city where they're interpreted to be both on a reservation, but they're also in a general city within Nebraska. So that makes their status a little bit complicated. And because of this, I did go to the tribal officials and sought their approval to conduct the research, which in the end, it seems that if the tribe is not involved directly, that process is not really essential or required at that point. But I did think it was important to discuss with the tribal officials what we were doing and how we were hoping to engage with their community members in order to get their support and their feedback. Another aspect that had, I think, a significant impact on the data that we collected in the research process were a couple of historical events that took place during the time of our data collection. So these came up after we'd submitted the funding proposal and after we got an IRB approval. So it really couldn't have been, I don't think, anticipated by anyone, but I do think they had a significant impact on the research process here. So the first was the protest at Standing Rock here. So a number of people on my research team were making trips up to North Dakota every 2 weeks to support their brothers and sisters up there in the protest. So this had an impact, I think, both within the data collection, to where if somebody is gone for 2 or 3 days every 2 weeks, obviously they're not able to recruit or collect data within the process. But a more important aspect to me, I think this arose some of the larger consciousness of people in the Native American community, even across different nations. So we saw that some of the people who were most involved with this process really had nothing to do with the Lakota Sioux nations, but were nonetheless identified and had a great deal of solidarity with the people who were engaged in the process there. And I think this might have also increased some of the responses of the historical trauma. For example, one aspect of the survey addresses treatment by authority figures. So we can see that some of the conflicts at Standing Rock may have directly contributed to higher response rates than we had seen in previous comparison studies, which I'll show you a little bit later. A second historical event that occurred during this study was that there were increased efforts to shut down the liquor stores in White Clay, Nebraska, which, if you were familiar with this, is a small town in Nebraska that's just over the border from the Pine Ridge Reservation. And on the Pine Ridge Reservation, alcohol sales is illegal, but we'd see that many of the individuals from the tribe went to White Clay to buy alcohol, and basically the main purpose of that town seemed to be to sell alcohol to Native Americans from Pine Ridge who could not buy it there. So we saw high rates of obviously alcoholism, alcohol-induced death, crime, and many aspects there. So during the study, there were increased efforts to shut down these alcohol stores and to get the government officials to revoke their liquor licenses. And I think with this, similar with Standing Rock, is that we saw many of the people involved most actively in this process were not related to the Pine Ridge Reservation really in any way, but we saw kind of expanding solidarity across Native American nations. And I think this might have been another aspect that increased our responses with regards to historical trauma. In particular, one of the questions on the historical trauma scale assesses for how often a person thinks about losses of their people due to alcoholism. So here's the first results table from our historical trauma study. So you can see that the loss is listed here as, for example, loss of our land, loss of our language, loss of our traditional spiritual ways. And then the individuals asked how often they think about those losses, could be ranging from several times a day, daily, weekly, monthly, yearly, or at special times, or never. So this obviously provides quite a complex table, and that is not easy to boil down into one number or one average, so that makes it somewhat challenging to compare to previous studies here. And then this is the table with the historical loss associated symptom scale. So this asks the respondent when they think about these losses, do they feel sadness or depression, anger, anxiety or nervousness, and so on, and then asks them how often they feel that way, always, often, sometimes, seldom, or never. And again, with this breakdown and so many data points here, it is difficult to compare to previous studies. This table breaks down the mental health symptoms that we analyzed. So for this is the American Indian sample here, and on the right side we see the normative sample that we compared to as far as from the national study. So we can see that there were several areas where our Native American sample had significantly higher rates than the kind of reference population. These were in aggressive behaviors, alcohol, drunk days, also thought problems, which is covered up here. And again, I think that relates more to spiritual practices or experiences than it does to psychotic symptoms and obsessive compulsive problems. So we did discuss a number of these during our community dinner where we reviewed the results. And so, for example, some of the externalizing problems and some of the aggressive behaviors people thought might be due to some of the socioeconomic situations in which many Native Americans find themselves, to where they might be kind of prompted to act out in these ways in order not to be victimized in various ways. So these were more, I think, as a result of unfortunate circumstances than anything else we might use to explain them. So as I mentioned previously, this historical loss scale does not lend itself to easy comparison, as there are so many numbers to compare. But I did try to break down and compare to two previous studies. One was conducted in 2011 and another in 2012. And these were the percentage of respondents that stated they thought about these losses daily. So we can see there are potentially some significant changes here, to where we see 2011 it was 11.7%, 10.2%, in 2012 jumped up to 36% in our study. And we can see that most of these are quite a bit higher in our current study than they were in the previous studies. Again, there could be multiple factors to help explain this. I think a couple go back to the historical phenomenon of the protests at Standing Rock and the efforts to shut down the white clay alcohol sales to individuals from the Pine Ridge Reservation. The next study we conducted was one that looked at substance onset among urban Native Americans. So I think one unique aspect of this study is that I worked with lay community members and basically trained them to assess for criteria of substance use disorders. So really, there are a set of 11 criteria that are laid out in the Diagnostic and Statistical Manual from the American Psychiatric Association. And these are used to determine whether or not a person meets criteria for a substance use disorder. So really, traditionally, there are only a handful of professions that are able to do this, including psychologists, psychiatrists, psychiatric nurse practitioners, and some forms of therapists who can make this determination. However, with regards to this community in particular and the sensitivity of substance use, I thought it would be worthwhile to go through and train lay community members who have relationships, who already have the trust with the individuals in the community, to be able to do this, so we didn't have to bring in some outside psychologist or another unknown person who wouldn't already have that trust. And really, the process isn't extraordinarily complicated. So I did train a couple community members in how to do this, and I think they did a very good job in helping to ask questions to distinguish between people who likely had a substance use problem in the past and those who did not have a substance use problem in the past. So we recruited 40 Native Americans within our two cities who had a history of addiction and 40 who did not have a history of addiction. We then looked at differences as far as, for example, age of first use, personal history as far as being in the foster care system or spending time living on a reservation, or other factors. We also looked at social context of first use. So we asked them, did you first use with other Native Americans, with non-natives? Did you first use with family members, friends, or other people of different relationships? And so we're still in the process of analyzing this, but we hope that this will provide some insight as far as how Native Americans who go on to develop substance use problems originally start. And so with that knowledge, we should be able to help inform some prevention programs to say if we can delay their substance use by, for example, 2 years, or if we can provide different social contexts, that we can help to reduce the chances that that individual will go on to develop a problem with addiction. The project that we're working on now are a couple studies regarding Native American peer recovery coaches. So we recruited Native Americans in Lincoln and Omaha who had a history of addiction to train as peer recovery coaches. So these were people that were a little bit further in their recovery process and hadn't used in the past year or more. And then we had a specific 3-day training program where we flew in some trainers that were specific to Native Americans. And so with this culturally specific program was able to draw upon the tradition and the values that were unique to many Native American groups. And so with this, the thought is that these coaches can draw upon many of those strengths in order to help bring individuals back to their Native American roots, which in large part does not allow for or at least encourage addiction. I've heard many people say that, for example, you can't go to a powwow or a sweat lodge or things like that when you're drunk or high. So drawing back some of these traditional spiritual exercises could be helpful in the process of addiction recovery for people. And with the pandemic, we've had to change these methods to involve all distance methods as far as describing the study, obtaining consent, conducting the surveys over the phone, but then also the distance support is something that is unique to this study, where in the few previous studies that have been conducted most often involve face-to-face interactions at least at some points, whereas during this pandemic we are using all phone or video conferencing, and this also allows for more coaches to interact with individuals who aren't in their same city. So we have 3 groups basically, or 3 geographical areas in this study. One is that we're looking at urban Native Americans who live in or around Lincoln and Omaha. Another is that we're looking at rural populations. So these are Native Americans who live in 4 small towns in western Nebraska. And the third setting is on the Santee Reservation. So there are a couple other points or examples that I wanted to bring up to highlight the importance of involving Native Americans in becoming researchers. So for example, one is tobacco use. So I see this as very different between Native communities and non-Native communities in some aspects. So for example, the survey might ask about tobacco use, whether a person ever has used or typically uses tobacco. And so really an important distinction to make here is whether a person uses in traditional ceremonies or whether they use smoke cigarettes on a daily basis. So obviously a person that smokes tobacco twice a year and doesn't really inhale within a sweat lodge twice a year, that's going to constitute a very different level of risk for respiratory problems than a person who smokes 2 packs a day. So understanding differences like this is, I think, really essential in research to help improve the health of Native Americans across the country. Another reason I think it's critical to have more Native researchers is that they come with an internal perspective, which I think is oftentimes more holistic than we do coming from the outside. One example as I use is of smudging. So there's been some discussion in the literature and saying that the smoke from smudging releases negative ions and produces these positive benefits, which that may be true, but I think that fails to capture the majority of the effect or how smudging works. In my mind, it's much more plausible that smudging works through bringing people back to their roots, back to their ancestral spiritual practices, back to their ancestors, and helps through that way rather than just releasing negative ions. There are a number of other principles of conducting research with Native American communities that I wanted to at least mention here. The first is that there are a number of very wide-ranging factors that impact health, including social environments, education, and responses to colonialism. And I don't believe that we've done the best job in research at really capturing all of these elements. To be fair, it's very complicated to capture so many elements within the context of one study. So for example, if we're going to look at all of these factors, it would most generally increase our sample size much beyond what we had originally had allocated and had budgeted for. So many of these projects may not be feasible to really look at all of these aspects. Also, any research conducted with Native American communities must take into account historical trauma. And in particular, even more just beyond historical trauma, must take into account the specific historical traumas experienced by those individual tribes. So some tribes faced boarding schools and relocations, others did not. So each different tribe had a different set and different extent of historical traumas that need to be accounted for in the research. Another factor is that cultures may vary across Native communities, but there's a common theme that's been identified, and that is that an imbalance in cultural forces can produce ill health. And this is another area which I don't think we've done the best job at capturing or quantifying in any way from a Western perspective, so it really needs more of a Native approach, I think, to address this fully. In addition, culture can be a tool for health promotion. I think we've done a better job at identifying this in the literature more recently, especially with subsets of groups such as Native Americans, where they've identified traditions and parts in their values and their history that can be used to promote health. Another aspect is of cultural safety, and that the activities must be based in the culture of the individuals. I think this is another aspect that hopefully researchers have done a better job in recent years of addressing than has been done in the past. Another factor is that communities must be involved in all aspects of research, from conceptualization to acting on the results. So I'm sure you've probably heard of community-based participatory research, but this is really critical with many minority groups, including Native Americans, where we really need to focus on research that is important to the Native community or to the community that we're working with. If an outside researcher comes in with their own set of predetermined ideas and goals, they're unlikely to be successful if they don't match those of the community. Community members may not have the research training, but they are essential to research. So this can be frustrating to researchers who are used to working, for example, in hospital-based research, where everybody pretty much has the background to do what they need, they have the resources, and everything can get moving quite a bit more quickly than we can out in communities where people may not have that research training. And so this can take more time to train people. For example, in my study where we train people to identify probable substance use disorder. But in the long run, I think that we've seen that the results that we get are well worth the extra effort that we spent on the training. We also need to increase the number of Native researchers, providers, and educators, and really provide an increased representation along the full range of professions. Many problems require multifaceted activities and programs to really leverage Native traditions. This is another aspect which is often quite tricky within the context of research. With most researchers and most funders want to go in and they want to provide one intervention, compare it to existing practices or compare it to a control group and see what the outcomes are. Whereas it's much more difficult to really take a much more comprehensive view of a community's existence and to use those traditions. This was a good quote I ran across that says, researchers need to do research with the tribes, not on them. And I think this really captures part of the divide that we've seen in research versus in the past versus hopefully our current view. Now, when we apply for IRB approval, we often see that the language they use is we have research subjects. Now, I always prefer the term participants, where the individuals are an active part of that research. They help, in many cases, design the study. They help with the implementation. They may help with data collection, and they help with interpretation. They're not, in my mind, subjects like we would have an animal trial where we do something to an individual, see how they respond, and then look at the results. So they're really a more active participant in the research from my perspective, and that's how I think we can be most successful. I'd next like to go through a number of quotes which I found and I think highlight some important aspects of research with Native American communities. I wish that we were meeting in person or at least synchronously so that we could have some discussion around them, but I think at least highlighting these quotes can bring us forward some important principles here. The first is that healing is different than treatment. And I think this is something that is very commonly known within Native American communities, but difficult to look at in terms of research. So again, within research, we're wanting to provide one very limited, well-defined intervention and identify the outcome. Whereas healing is much more difficult to measure. It's easy to measure things like blood pressure, blood sugar, and even depression we can measure to some extent, but how a person measures healing overall is a much more difficult concept to quantify, I would say, in most cases. The next quote is, wellness is more than the absence of disease. It has spiritual, emotional, and cultural dimension that extends beyond health care into the community. And I think this is similar to the first quote in that within research we want to look at very well-defined outcomes. Does a person develop cancer or do they not? Does their blood pressure or blood sugar improve or does it not? But really, this quote identifies a much broader perspective in saying that we're looking for more than the absence of disease. We're looking for overall health, which again is much more difficult to quantify. The next quote is, good health involves harmony, balance, and rhythm, not just the absence of disease. So quite similar to the first two quotes and equally difficult to quantify within the context of research. The next quote is, healthcare by itself does not guarantee good health. Many other aspects or factors are involved. And so I think that's clearly true, but again, difficult to measure. Oftentimes our public policies are going to want to institute programs which help increase access to healthcare. But as we know, this is often not sufficient for many people to improve their health and longevity. The next quote is, more important than the newest technologies are transportation, nutrition, sanitation, and other basic services. So I think this is important. It comes to mind, when we lately have an app for everything that we think is going to solve all these problems for us. But in reality, it turns out that when people don't have many of their basic needs met, that anything we try to add on top of that will really not be as effective as we would need it, or may not be effective at all. Next quote is, cultural humility is a critical dimension of delivering culturally safe care. And we'll talk about that in a little bit more detail in a bit here. And the next is, given the rates of readmission and hospital-acquired infections, the perspective common in Native communities is that hospitals are a place where people go to die is not surprising. So this can be a challenge, especially if we have Native healthcare providers and Native American researchers, for example, conducting research in hospitals. This may be a difficult situation, may need to take into account some of these perspectives. Next quote is, equity is important because everyone does better when everyone is doing well. So I think this is a great feature, somewhat unique to many Native American communities, and they have a more collectivist mindset, and this stands in my mind in very stark contrast to the more Western perspective that's focused on competition. And this is even the case in research, where you have many proposals for research go in, and maybe only one or two or however many are funded. So there's great competition in that way too. But really, I think we need to get to the perspective where everyone is working together towards the common goals of increasing health. Next quote is, medicine is a compassionate and caring field, and the people who choose that profession are people who appreciate the importance of culture and can incorporate it into practice. So I take some issue with this quote, because clearly in the beginning of this presentation I highlighted some abuses both in research and in healthcare that show that this is not always the case. I think this is an ideal for us to live up to. So I do think this quote reflects the trust and the reverence with which the general public holds those of us in the healthcare professional field. However, I do think it's important that we all continue to work towards cultural competence and cultural safety, and encourage those of us around us to do the same. The next quote is, cultural traditions should reshape healthcare, not the other way around. And so this is difficult for many people in healthcare and in research in particular to accept, because oftentimes we come out with a health intervention which is shown to be effective in one setting or in a controlled environment, but we need to then extend it to a broader environment. And this could really be the challenge as far as when culture is implemented and how it's helped to inform that healthcare delivery. Next quote is, the power of Native communities resides partly in their ability to convene as communities and identify what needs to be done. So again, we're seeing a highlighting of the communal aspect of many Native American cultures versus the individualism and the competition that we see more within Western mindsets. The next quote is, the power of the community that is well known among Native peoples is being realized technologically through such means as Facebook. So this is an interesting phenomenon that I've seen as I followed these through Facebook, which I use primarily for work, because oftentimes it's difficult to keep track of what's going on within the Native American community without Facebook, as many of their events and much of their news is not publicized elsewhere that I've been able to find. So it's interesting to see how Facebook and other social media platforms have really allowed people to connect across nations and across geographical areas and really build solidarity among Native American groups. Another quote is, healthcare training generally does not reflect cultural differences. A new emphasis on relationships and two-way exchanges is essential to accommodate the effects of culture on health. So I think we've been doing a somewhat better job in education as far as educating about cultural differences, but clearly more education on this aspect is needed, and continuing education as far as when people are out in practice or conducting research to continually reassess how culture and cultural differences are affecting and impacting their work, and even more so how those strengths that we see within various cultures can be used to help promote health. Next quote is, paradoxically, during a time of radical change in science, healthcare, and government, people will need to change to preserve and protect the cultural traditions that contribute to good health. So I thought this was a powerful quote, really highlighting some kind of paradox here, in that we're seeing such radical change with technology, a fast pace of change, but at the same time, we need to preserve many of the traditions from the past that have been so helpful for people over the generations. And in some respects, we can kind of merge those two, and that many of the technological aspects that have come about can be used to help leverage their resources and help promote the retention of those cultural aspects. The most kind of salient example that comes to my mind is the preservation of languages. So when we look at tribes that are trying to preserve their languages within limited populations, we can see that they have a much easier time doing that today with all the technological resources than they would have had 20 or 30 years ago. And next is a similar quote here. One reason it is important to preserve culture is that culture is a tool that can be leveraged to create change. So again, the dichotomy kind of between change and between building on the strengths of previous generations is something that we need to look at more. The next quote is, self-determination equals power, and power contributes substantially to health. So I think we can see this clearly in a number of Native American reservations where they've been placed in areas they did not choose. They've been confined to areas with few resources, And so it's, I imagine, easy for those populations to feel downtrodden and not to feel hopeful about their future or their health. But as we move towards more empowerment, and we see that in recent news, recent events where some tribes are purchasing back their ancestral homelands, that hopefully this can contribute to a broader feeling of power among many Native American groups. We'll next talk a little bit about some of the social determinants of health, which I imagine you guys have had in other modules here. A good quote I ran across was that every disease has two causes. The first is pathophysiological, and the second political. So I think in research and healthcare in general, we're good at identifying many of the pathophysiological conditions that lead to the disease. We're not as good or in tune with identifying the political underpinnings of those diseases. So some of the social determinants that have been identified have been income, social support networks, education, employment, social environments, physical environments, coping skills and resilience, childhood development, biology, health services, and gender. Some research has also gone into identifying some of the broader determinants of health, particularly among Native American groups. These include culture and cultural continuity, access to services and supports, colonization, globalization, migration, poverty, self-determination, and territory. So again, these are things that commonly we don't look at as much in research because these are often more difficult to quantify. For example, if you want to say what is the effect of globalization on a particular community, that's difficult really to pin down within a single number or even a group of concepts. So these are more difficult to analyze, but we do need, as researchers, need to put more thought into how these might affect many of the health outcomes that we're seeing. Because if we just go forward with a reductionist perspective and say that the health is a result of diet, exercise, and these other limited things, we're going to be missing a large part of what is contributing to their health or their illness. Next, I wanted to circle around and briefly talk about some of the aspects of the cultural competence continuum and particularly how they can affect research. So we can go through a process where you guys have probably seen this before, where you start with cultural destructiveness, cultural incapacity, cultural blindness, cultural pre-competence, cultural competence, and cultural safety. We'll next go through some of the brief definitions of each of these. So cultural destructiveness has been defined as the imposition of foreign and damaging systems, actions, and policies with the intended outcome of disruption or destruction of existing cultures and structures. So we can clearly see that many of the interactions between the federal government or even local governments or even individuals was at the level of cultural destructiveness early in the interaction between colonists and Native Americans, where the colonists brought in their foreign ways, their foreign materials, and oftentimes with the intention of causing the disruption because the Native Americans were taking up land that they wanted or other issues. The next step is cultural incapacity, and this has been defined as the ongoing withholding of recognition and respect for the cultural structures of the client or the client's community or population. So this is a little bit less well defined, but I think that we can clearly see that in some respect within the U.S. government went through a period of cultural incapacity when hopefully they were not at the level of committing acts of genocide any longer, but they were really withholding that recognition and that respect for the culture and the traditions of many Native American communities. The next stage is cultural blindness, which has been defined as the deliberate act of development and delivery of programs and services in a manner that pretends that culture does not matter or that seeks to treat all clients equally. So I think we can see that more recently, maybe in the 60s or 70s, where outside groups might have gone into Native American communities seeking to offer help without any recognition that the culture has a significant aspect on how the people there might have responded or adopted those interventions. The next stage is cultural pre-competence, or also known as cross-cultural care, and this has been defined as the recognition that culture does matter and that the culture of a particular client or community may be different from that of the service provider. So this is the beginning kind of level of that recognition. However, hopefully people go beyond that, just beyond recognizing that this other group might be different and they might think differently from me, to understanding. The next stage is cultural competence, which has been defined as awareness of one's own culture and the culture of clients and communities and how these impact health and healing relationship being developed. Culturally competent care will be as congruent as possible with the culture of the client. So this, we're moving towards more of an ideal relationship and recognition of the culture and the impact that it has on the individuals. However, the ultimate goal in many aspects is been defined as cultural safety, which has been termed complete congruency between the culture of the person seeking services and the services being provided. A goal for all healthcare systems and all clients, but often a continuous and iterative process to be striven towards and not necessarily an end result in and of itself. So I think this is really our ultimate goal here, and that hopefully when we see greater numbers of, for example, Native American healthcare providers, that they are more in tune with this and have an easier time moving towards cultural safety. But the rest of us who are not from that background obviously need to progress towards this as well. And I think the second part of this definition is really critical, where it's really not a goal in and of itself, but more a process that we're seeking towards. And I think it requires continual reassessment as cultures change and adapt to systems around them. So too do the healthcare providers or the researchers need to adapt and continue to develop their understanding of that culture and how it interacts with the people and their health. Another quote I liked here was that cultural humility incorporates a lifelong commitment to self-evaluation and critique, to redressing the power imbalances in the physician-patient dynamic, and to developing mutually beneficial and non-paternalistic partnerships with communities on behalf of individuals and defined populations. So this really describes a lifelong process that we as healthcare providers or healthcare researchers need to engage in order to interact in the most effective manner with subpopulations that we're working with. Next, I'd like to present a short section that includes some reflections on culturally safe research. First quote I'd like to present is research that is focused on community priorities, needs, and realities. Now this sounds to be very obvious and really elementary in research, but really I think represents a stark contrast to what we saw in the early days of research with Native American communities. In these situations, most often researchers went in with their pre-existing ideas, implemented their plans, and oftentimes failed because they did not take into effect the priorities, the needs, and the realities of those communities. Next is that methodologies are culturally appropriate and respectful. Again, a significant departure from the early days of research with Native American communities. The research process is open and inclusive. This is something I think we haven't done as well within research as I think we need to. That we really need to involve the community if it is really to be community-based participatory research, where we start with the priorities of the community, we involve the community at every step of the way, up through data interpretation and implementation of any outcomes of the research. Next is that research designs are credible and of high quality. Next factor is that due consideration is given to ownership, control, access, and possession of the data and research outcomes. And this is another factor that has been difficult for many researchers. If researchers really put in a lot of time and stake a lot of their career on these aspects, then it can be difficult or daunting for them to put someone else in control of that process. So if we go out and we get funding for a particular project, we spend 2 or 3 years collecting data, only to have someone else control that data, they may or may not allow us to use it in the way that we need to get the results that were intended, then this can be a difficult thing. However, I think this is where it's important to build mutual trust from the beginning so that everyone has the same goals, same understanding, and that there are no conflicts along the way. Another quote is that healing is a central concept distinguished from treatment or cure. Again, this is a broader concept, I think, than we see oftentimes in Western medicine, where again, healing is a difficult concept to quantify, to analyze statistically. It's easy to identify cure as far as how many people are in remission from cancer or how many people's blood sugar is dropped within the normal range. But clearly, we're looking at much broader concepts than that oftentimes when we were working with Native American communities. Next quote defines wellness as maintenance and enhancement of health and well-being for individuals, families, communities, and nations through the restoration of balance at each of these levels. So this is often related to the previous point, and very often very tricky within research. If I go forward with a proposal and say I'm going to increase wellness within work with a particular community to increase wellness, that's not likely to get funded because, again, this is difficult to quantify. How do we know if we've met that goal? So this is really where we need to work with the individuals within the communities to help provide, help define some of these aspects so that we can get the outcomes that the funding agencies are needing, while at the same time meeting the broader needs of the community. Next quote is, "The pursuit of holism is important in approaches to problems, their treatment, and their prevention. Multifactorial analyses of dynamic systems is the essence of consideration of broader determinants of health." So I think that quote is obviously quite wide-ranging and speaks quite well for itself. All right, there are a few final quotes that I wanted to go over here because I thought they brought forth some good points. The first is that good research considers the root causes of ill health and the requirements for optimal health that are particular to the experiences and histories of indigenous peoples. And with many of the points before that, I think this is an area where we as researchers have not done the best job at taking a more comprehensive look at the communities to find out what is really going on. More times than often than not, I think we're going in with a particular intervention, hoping to find a quick short-term outcome and leaving it at that. The next quote is that good research respects the worldviews of indigenous peoples on connectedness, respect, balance, and the equal importance of physical, emotional, social, mental, and spiritual health. So I've talked several times about the difficulty in approaching these wide-ranging concepts within the confines of research. Another quote is, good research provides insight into key health issues and offers the potential to improve promotion, prevention, treatment, rehabilitation, and family and community support. So this is a challenge in research in that oftentimes we're focused on one particular aspect, whether we want to prevent an illness or a disease, or we want to treat a certain disease. Usually one research project cannot affect the full range here, but if we take a broader view, and in particular with collaboration with the communities, then hopefully we can attain the point to where we are addressing all of these at some point throughout our interactions. Now the last quote is, good research addresses particular issues within the context of the long-term aspirations of indigenous communities to be self-sustaining, healthy, and prosperous. So I think that's really kind of the epitome of what most communities strive for, and that they don't want to be dependent on outside resources, but unfortunately they've been put in dependent positions where they are needing those outside resources, at least temporarily. Unfortunately, temporarily has been turned into hundreds of years, but hopefully we can turn this around at some point. And lastly, I'd like to leave you with a few of my final thoughts here. First is that research is critical to helping guide the most effective interventions to help promote health in Native communities. The second is that researchers will only be successful if they engage with communities with humility and as equals. And finally, more Native researchers and healthcare providers are needed if we are to help Native communities attain the health that they deserve. Thank you for your attention, and please let me know if you have any questions or comments.